The Glidescope video laryngoscope has become a popular tool in the management of the anticipated and unanticipated difficult airway. One of the main advantages of video laryngoscopy is that it allows other healthcare providers to visualize the airway and assist in intubation. The Glidescope is available with a detachable blade that can be sterilized and reused, as well as a single-use disposable blade that fits over a flexible wand. A Glidescope stylet has been specifically designed to facilitate alignment of the tip of the tracheal tube with the glottis. Whenever performing an intubation, ensure the audible pulse oximeter tone is enabled. There are 4 important steps that must be completed to avoid patient injury when intubating with the Glidescope. The first step is to look directly into the patient's mouth to place the Glidescope blade. The second step is to look at the monitor to confirm glottic visualization and fine-tune the placement of the blade. The third step is to look directly into the patient's mouth as the styleted endotracheal tube is placed into the posterior pharynx. The fourth and final step is to look at the Glidescope monitor to align the tip of the tracheal tube with the glottic opening. Once the tip of the tracheal tube is aligned with the glottis, the stylet and tube are advanced together into the tracheal lumen. The stylet is then removed and proper tube placement is confirmed with direct visualization of the tube passing between the vocal cords, capnography, and bilateral auscultation of the chest. In summary, it is important that the blade and stylet are introduced into the mouth under direct visualization. The monitor image is used to fine-tune the placement of the blade and advance the tracheal tube into the trachea.
Next, we will demonstrate a Glidescope intubation. For this, we will need a Glidescope with an appropriately sized Glidescope handle. We'll also need a standard endotracheal tube and a specifically designed stylet for the Glidescope. Here you want to insert the stylet before you start and have it ready beside the patient. We also need an appropriately positioned patient. Here you can see that the patient is in a sniffing position with flexion at the lower C-spine and extension at the upper C-spine. For insertion of the Glidescope, you'll be required to open the patient's mouth. And this can be done by a couple of techniques. The first technique would be to grab the occiput with the right hand and to increase the extension at the AO joint. This will naturally open the patient's mouth. The other technique is called the scissor technique, using your thumb and your middle finger of your right hand. As you can see from the screen, I cross my fingers over and scissor them out to open the patient's mouth even more. For insertion of the Glidescope handle, what I will need to do is open the mouth and look directly inside the patient's mouth in order to avoid damaging teeth, as well as to navigate around the tongue. I can then look at my screen to look for some recognizable structures. Here at the top of the screen, you see that the glottis is coming into view, with the vocal cords being white and the entrance to the trachea being the dark circle in the middle. I then will introduce my endotracheal tube, again under direct vision, looking inside the mouth to avoid dental damage as well as navigating around the tongue. Once I am firmly inside the mouth, I can then look at the screen and aim my endotracheal tube for the glottis. Once I enter in through the vocal cords, then I will have an assistant pull back my stylet and I will continue to advance the endotracheal tube. From here, I will remove the Glidescope handle. I will put air in the cuff of the endotracheal tube, and then I can secure the endotracheal tube appropriately.